Good morning, everybody. Welcome to Sleep Medicine Grand Rounds. We'll go ahead and get started. Today we have Dr. Dennis Auckley, Professor of Medicine at Metro Health Hospital, and one of our premier sleep experts in the region and the country, who's going to be talking to us about obstructive sleep apnea in post-CVA patients.
All right, thank you. So Sushil asked me to give a talk. I gave him a list of topics and he chose this one. You could ask, why am I giving this talk? So first disclaimer is I'm not a neurologist. I admit that up front. And then you may also be wondering, this seems like a very specific topic, but I guarantee you, unless you're gonna be doing strictly peds, you know, as you are out in practice, you're gonna come across all these issues related to sleep medicine and challenges that we have, and people are going to come to you from other specialties and say, hey, we got a problem, what do we do about this? And that happened to me relatively early on in my career at Metro, where you know, information started coming out about this, and actually it was mostly our rehab folks that really jumped on this kind of bandwagon about all these patients who have had a stroke and might have sleep apnea. And so I got involved with this early, just from a sort of quality and workflow and procedural process at Metro Health. So we've had a protocol in place there for a while. So it's become sort of an area of interest, kind of a hobby, looking at these patients and trying to figure out what to do with them. So what we're going to talk about today is evaluation management of these patients. So just a couple of sections up to date, one on inpatient sleep, which touches on this a little bit, but not that much. So we're going to review just epidemiology of sleep apnea in the post-stroke patient population, because it's clearly different from the general population. Talk about the consequences that this may have on patients who, once they've had a stroke, the diagnostic strategies that we can utilize, what's the information and data about that, and then we'll talk about sort of treatment and what we know about that, which is an ongoing area of investigation. So I think everybody knows this information about prevalence of sleep apnea in the general population. Back in the 1990s, every article started 2%, 4%. Then they updated the Wisconsin sleep cohort. It went up to 5%, 14% for women and men. It's very important to recognize that this is the HI 15, or I'm sorry, yeah, HI 4%. So using a very conservative definition, and they use a cutoff of 15 to define this. So you go more typically what we work with in clinical practice, HI 5, and if you use the 3% arousal index, it's going to be higher than this. But this is kind of what's sort of accepted baseline, often quoted in the literature. Obviously, because of sleep apnea's association with a number of cardiovascular and metabolic diseases in certain populations, the prevalence is going to be much, much higher. And so these were studies actually that came out in the 1990s, looking at obstructive sleep apnea in patients who had a stroke. So this was kind of as I was starting to hear about this information. So one thing to note is that the cutoff that in the post-stroke literature, for some reason, they've really stuck on this HI cutoff at 10. I'm not really sure why. You know, it's different from what we tend to think about, 5, 15, 30. But most of the stroke literature seems to hang upon 10 as using the defining definition for sleep apnea. And the HI definitions vary, obviously, 1990s to early 2000s. These were different times, different definitions. They vary quite a bit since then, so it's not always exactly the same. But what you can see here is just an age-matched control population showing rates around 10 to 20%. But in the post-stroke patient population, it's up over 60 to around 70%, so extremely high. And this was one of the meta-analysis. There was one done more recently, only a few years after this, looking at all these studies now, looking just prevalence of obstructive sleep apnea in patients who have had a stroke. Again, using the HI cutoff of 10. And you can see it's quite high, so it's averaging probably around 60% or so. And then if you use sort of more traditional cutoffs, the 5 cutoff, it's up to 70%. If you want to really just look at patients that have severe sleep apnea, it's a third of them will have severe OSA. And what's also of interest is that a very small percentage of these patients is actually central apnea. So there's always discussion about stroke and central apnea. It turns out that's not really that common. The predominant form of sleep disorder breathing in patients who've had a stroke is obstructive sleep apnea. And we'll come to this in another slide here, but sort of there's always a question about chicken and egg. You know, is the stroke causing the sleep apnea, or do these patients have sleep apnea and then had a stroke? And one thing that's of note here is that some of these studies actually looked at just patients who had TIAs, so they didn't actually have any, you know, cerebral or brain damage as a result of their stroke. So they had a transient event, but their rates of obstructive sleep apnea are exactly the same as those who've had a stroke, which was one of the arguments about why the sleep apnea probably predated the stroke. So when you look at these patients, most of them, and you talk to somebody, talk to their bed partner or spouse or whatever, most of these patients have had symptoms of sleep apnea prior to their stroke. And then, as I just mentioned, the rates of TIA, the stroke rate is the same as it is for those who've had a stroke. And then when you look at sleep apnea, so if you thought it was due to the stroke, oftentimes the stroke recovery happens, you think the OSA would get better over time. It does, but it gets better by a very small amount. We'll look at that data in a second. When it does improve over time, it's mostly related to improvements in dysphagia, so strokes that affect swallowing and the upper airway muscle control. And then in some patients, particularly those that have had more hemorrhagic strokes, it's often related to central apnea. It's getting better over time. There's a question about a positional component, but that really hasn't been looked into all that well. So this is some data. Again, these are fairly early studies looking at patients who had strokes, and then they followed them over time. So most of these studies were 3-month follow-ups. The one on the far right with the gold bar, that's just an age-matched general population prevalence. Or I'm sorry, not prevalence, AHI. So what you're seeing here is that these are average AHIs, and these patient populations, the numbers on the bottom are the number of patients that are on each of these individual studies. So you see it gets better, but it's not really improving that much. So you have most of the patients are kind of in the moderate to severe category on average, and then over time, so around 3 months out, they're still in the moderate category in terms of their sleep apnea. And these are PSG-based studies. There was a more recent one, which I thought was kind of interesting, that it was really trying to get patients who got thrombolysis versus no thrombolysis. And this is, they did home tests, so it's looking at a respiratory event index using a 4% criteria here. So again, pretty conservative, probably underestimating the severity of sleep disorder breathing. But you can see that their HIs are in the 25 to 30 range at baseline, their REIs. And then they repeated the study at 6 months, so it's a little bit further out. And you saw those that got thrombolysis, it improved a little bit, but it's really only, REI 2 events less per hour. So it's questionable, not really any clinical significance in those that weren't thrombolyzed. The event index did not really change. Interesting, at baseline in this group, 93% had REI, 4% more than 5. So, so it's very, very common, but, so why should we care about it? So we know in general that sleep apnea is associated, obstructive sleep apnea is associated with increased mortality. This is one of the best done studies looking at this, fairly large study, 6,000 individuals followed over time. They had almost 350 that had severe OSA. And there's sort of a dose-response relationship in terms of looking at the apnea-hypopnea index and survival rates. I always like to show this to my primary care providers because everybody argues me for screening for prostate cancer and breast cancer, but as we'll come to, advocating screening for obstructive sleep apnea is not has not been recommended, despite the fact that if you have severe OSA, your survival at 5 years is worse than if you have prostate or breast cancer. So in patients who've had a stroke and they're subsequently found to have obstructive sleep apnea, does it actually impact outcomes? And the biggest outcome we're always concerned about is mortality, and so does it increase that risk? So this is a number of studies. This was from a review done in 2014 that looked at mortality over time. You can see that these aren't huge studies. They range from 90 to about 160 some individuals per study. And the follow-up range is highly variable from anywhere from a half year up to 10 years out. Interesting, all the studies found a relative risk or hazard ratios that were statistically significantly elevated for increased mortality based on varying cutoffs, with the exception of 2. These 2 studies just highlight briefly. This one by Bassetti, so they looked at individuals AHI more than 30 compared to less than 10, and you can see the confidence interval overlaps 1. But when you look at the absolute numbers, it's 22% versus 9% in terms of mortality. So you got to imagine the study probably underpowered. And this one also did not find an increased risk, but they only had 4 patients that died in one group and 2 in the other. So it was a pretty small study. Probably the best study is one by Salin, which they used an AHI 3% criteria, and they did a big adjustment for all sorts of other risk factors. All the other studies were not adjusted. And they found a hazard ratio of roughly 1.8 that was significant, just comparing moderate to less than moderate sleep disorder breathing. So when you do the forest plot on this, combine all these studies, it does end up being significant 1.7 with those confidence intervals in a significant range. So it's thought that this, if you've had a stroke and you're found to have sleep apnea, at least moderate to severe sleep apnea, it probably does increase your risk of mortality over time. So besides mortality, we also worry about other, medical conditions that can develop. We know that sleep apnea has been associated with all these cardiovascular diseases, including stroke. And it's thought that many of these things, there's a cause and effect where the OSA is leading to or contributing at least to the development of some of these issues. And a lot of these issues are also part of the pathway to, ending up with the bad outcome of a stroke. So we know that hypertension, vascular disease, heart rhythm problems are associated with that. So in just kind of updating this talk, I was doing a quick literature search and found there's a new article come out. This is available EPUB. It's not in press yet. It's going to be in CHEST. It's a review by Mark Boulos and probably one of his trainees, I would imagine. But looking at sleep apnea, how it could lead to stroke. And so I think we're all aware of these pathophysiologic issues with the arousals, hypoxia, the pressure changes, sympathetic activity, inflammation, stress, oxidative stress, leading to the intermediaries of hypertension, vascular disease, AFib. And then you can get small vessel disease, large vessel disease, and cardioembolic events. So just curious in the audience, what do you think is the most common type of, when you look at OSA and patients who've had a stroke, what type of stroke is probably more commonly associated with OSA? Small vessel, large vessel, or cardioembolic? Any takers? I'm just curious because it's kind of surprised me a little bit.
What do you guys think?
Cardioembolic.
Cardioembolic? All right. Very good. So this was a study that actually looked at this, and it was it's kind of interesting. It's a large sort of retrospective database review. So not the highest quality data. I'm always kind of amused by this. I looked at 1,600 records that had been a diagnosis of a stroke and they had to have a PSG within a year. They excluded 1,500 because the diagnosis was inaccurate. That tells you how these databases studies. So they only have 53 subjects that had a confirmed stroke and had a PSG within a year. They looked at the HI cutoff at 10 again. So what they found was that the highest, the strongest association was cardioembolic disease. So the black columns are representing patients at OSA, and then the white are those that don't. So when you look at small vessel and large vessel, it's actually fairly similar in terms of the rates. So I was a little surprised by this. I thought it might be more like small vessel disease because we know how much OSA can contribute to vascular disease. And then subsequent data did look at, and we'll come back to this in a second as well, that nocturnal desaturation is probably is strongly associated with AFib and then stroke in these stroke patients. And so the whole issue about AHI versus hypoxic burden is probably significant. So this is looking at subsequent strokes. Another outcome is once you've had a stroke, you're found to have OSA. Patients who had a stroke are high risk for subsequent strokes. Does having OSA increase your risk? And then also incident ischemic heart disease. And so there's been a little bit of data looking at that. And the big message here is that yes, if you have OSA, found to have OSA after a stroke, your risk of having another stroke, a second stroke, is significantly higher than someone who's had a stroke and does not have OSA. Again, you can see the numbers down there, not huge studies, but certainly suggestive. So we know that in general, that sleep apnea causes a lot of problems in terms of depression, anxiety, irritability. Obviously, post-stroke depression is a big problem, so that may play into that. Social, sexual dysfunction, and neurocognitive impairment. There's been big interest in this in the last 20 years or so, how sleep apnea could be impacting the brain in general, in terms of looking at white matter changes, specific areas that these are occurring in, and how they can affect things such as intellectual ability, learning, memory, attention, information processing, etc. So if you've had a stroke, your brain's trying to recover, and you've got OSA on top of that, and we know that OSA in general is going to contribute to these things. This may be potentially augmented. So along those lines, there's been a number of studies looking at sort of what happens with patients after a stroke, comparing those who are then found to have OSA versus not. So this is a study of 80 post-stroke patients with OSA using a cutoff of 15 versus those that had a stroke did not have OSA. Those that had OSA were a little bit older, slightly heavier, and obviously had high ODI and AHI compared to those that didn't. So a lot of things on here, but what was statistically significant were that those, so this is just a point in time, sort of cross-sectional analysis. So if you had OSA versus no OSA, that after their stroke, they had reductions in attention, executive functioning, visual perception, psychomotor ability, and intelligence, compared to those that did not have OSA. So some of this might have pre-existed the stroke, but it's possible that also this could be a worsening factor as a result of the OSA while the brain's trying to recover. Then we looked at some more standard measures. So what you can see there is a neurologic status by a variety of measures. Statistically significant, or almost significant, was the United Stroke Scale, being worse than those who have OSA. The Canadian Neurologic Survey, I can't remember what that is, but it's a Canadian stroke scale, basically. Was significant. Functional independence was also much worse than those who had OSA. So this study actually came from the 1990s. So this is looking at doing a simple oximetry on these patients. And again, they use that cutoff of 10. I don't know why, but they're using the Barthel index as one measure of functional status. And what you can see is that at admission, patients who had oximetries more than ODI 3%, more than 10, or 4%, I'm sorry, more than 10, less than 10, were the same at admission, but then as they track them over time, looking at a discharge from rehab, so that's usually within 3 weeks, 3 months out and a year out. The patients who had OSA, that their functional recovery was actually worse. So as your Barthel index should be higher, meaning better function. So the patients with sleep apnea tend to recover worse. We did do a similar study at Metro. We never published this, but it was using the FIM index, which is just, I think, more commonly used in the rehab services these days. This is looking at ODI 3%. We broke it out into quartiles. So this is their FIM difference over the course of their 3 weeks on rehab after a stroke. And so the higher this difference is, the better. That means more functional recovery. You can see the first two groups. So we broke it into quintiles. So ODI 0.1 and 2, that's really considered probably not having clinically significant sleep apnea. And then you have 5, 10, and 36. So kind of correlating to mild, moderate, and severe. You can see there's a clear drop off once you reach that ODI threshold of 5 in terms of their functional recovery. So there's a fair amount, and there's other data as well suggesting that patients who've had a stroke found to have OSA, their recovery from the stroke is much worse than if you don't have OSA. So we know sleep apnea is underdiagnosed in general. Just remembering these things, the AHI 15, sort of a 5-14%. And so the study we did at Metro again a while ago, just looking at outpatient visits. This is just general primary care. These are actually a family practice clinic where we just went in and surveyed the patients after they came out from new patient clinic appointments. We used a stop survey, or stop questionnaire, and the prelim questionnaire. Finding about a third of these patients would be at high risk for OSA. These have predictive values around 0.9, positive predictive values. But then we looked, the green bar represents how often, this was talked about, discussed in any way, shape, or form during the visit. And we saw only a couple of the patients that actually had this brought up. So not really on their radar. This is not unique to Metro. There's all sorts of different methodology studies that have been done around the country showing very similar results. OSA is vastly underdiagnosed. As everyone knows, rule of thumb is probably around 80% still not diagnosed. And in the post-stroke population, so this was a study that Devin Brown did. I think it was actually a Texas database. They looked at 900, or almost 1,000 post-stroke patients in a single academic center not that long ago, and only less than 20% were offered sleep testing prior to their stroke. And then once they had a stroke, less than 10% were really evaluated by any kind of, just asking questions or offering them a sleep study. And more recently, our old colleague Brian Koo did, or actually, I'm sorry, not more recent, about the same time, did a study looking at a database of 9,000 veterans who'd had a stroke, or TIA, so 6 and 3, and only 6% of them had a sleep study prior to their event. So the thought is that this is probably pre-existing, and that once they've had the stroke, you're probably looking at a rich patient population that have longstanding OSA, and now they've had a bad outcome related to that, because it wasn't identified and wasn't treated. So, these are things to think about in the general population. Who should we screen for sleep apnea? Only when we think about it. Actually had, I'm not bashing neurology in general, but I had a neurologist, one of our old neurologists, no longer with us, told me he would ask if they would tolerate CPAP. And they said, yeah. He would ask them about OSA. If they said no, he didn't even pursue it. Only those in high risk groups, i.e. those with the stroke, should we just be screening all these patients routinely, everyone. So currently, as you guys know, the CDC, the US Preventive Task Force, and the AAFP, American Academy of Family Practice, do not recommend for screening for sleep apnea in the general population. However, this is almost 20 years old, based on the literature about the patients who've had a stroke. This is Madeline Griggs-Stamberger. She published an opinion piece suggesting everybody that's had a stroke or a TIA should go ahead and get a PSG. Nobody kind of bats an eye about getting an echo and carotid Dopplers and all these other things, which are just as expensive. But getting a PSG as part of the just systematic evaluation of patients who have ischemic stroke. So she's been arguing that for a while. So the ASM actually has recommendations for PCPs. This was published in 2016 about who they recommended should be screened. These are adults for sleep apnea, and you can see stroke is on the list. So if you have one of those comorbid conditions, they recommend obviously screening obese patients, pulmonary hypertension, et cetera. This has just been updated, so it's in EPUB as well. It's not quite published yet, but you can access it. So they've updated, took out resistant hypertension, just made a hypertension, and just any kind of surgical procedure, they should screen these patients. So stroke is on the list of who they recommend screening with sort of an appropriate standardized tool. So that becomes a little bit of an issue. So some folks for screening just do simply, asking questions about sleep apnea. We all know this, you guys know this information, don't need to belabor this point, but one of our classic symptoms is daytime sleepiness, right? So the post-stroke population ends up being a little bit different and a little bit problematic when you go to some of these standard questions. So this was a study where they actually looked at over 1,000 controls and then 100 patients who had strokes. They all had sleep studies, and they were just comparing, okay, those that don't have sleep apnea, mild, and then moderate or severe sleep apnea. And what they looked at was the Epworth and the BMI, and I've certainly seen this clinically quite a bit. So in those that have at least mild and moderate sleep apnea, you can see their Epworth scores. If you've had a stroke compared to the controls who've not had a stroke is considerably lower. They're in the normal range. So that's one of the problems with the patients who had a stroke, just asking if they're sleepy. They often are not. Some patients post-stroke, depending on where the stroke is, they're hypersomnolent, but more often they won't admit, majority won't admit to being sleepy. So if you did an Epworth screen as a screening tool, which is not a great screening tool anyway, most of these patients are not going to be sleepy. And then if you decide, oh, I'm just going to screen those that are obese, again, the body mass index in patients who had a stroke who end up having OSA, which is probably part of the reason they were missed pre-stroke, it tends to be much lower. So you can see in those with moderate OSA that their average BMI was only 27. So this would not, fit the typical screening criteria. And I've seen this plenty in our protocols we'll go through in the end here. I see it very often patients have BMIs in the mid-low 20s and just have these terrible looking oximetries. So what about, if you've had a stroke, does it matter where the stroke is? Can you determine, okay, I'm only going to screen patients based on if they've got a posterior circulation or whatever? It turns out, no, there's no correlation between where the stroke is and whether or not they have sleep apnea. So you can't use that at all. So what about, so physical exam, just history, physical exam may not be as reliable as they are in the general population. What about screening with questionnaires? So there's some data from some studies where they did the Berlin, the stop bang, and they did some modifications, taking out the neck circumference, because that's the one cumbersome part of the stop bang. Maybe doing some other manipulations. You can see the sensitivity, specificity, the positive and negative predictive values. So it's interesting one, there's a sleep inventory, which I think also came out of the Michigan group, where they look at sex, left heart failure, Epworth scale, large neck, weight in pounds, insulin resistant, and stroke scale. And the big thing they were kind of pushing with theirs is that their negative predictive value is 100% in their study. I think it needs to be validated, additional work. I haven't seen it published. But, in terms of your resource utilization and, if you can't rely on your history and physical exam all that well to help determine who needs further testing or not, screening questionnaire, maybe this could be a branch point here they scored low on the sleep inventory, but we have not utilized that. So in terms of diagnosing these patients post-stroke, so PSG obviously would be the gold standard, but it's not the easiest thing to do in this situation. Obviously, you get comprehensive data in relationships. If it's attended, that's helpful. You troubleshoot. Disadvantages, it's very costly. It is very personnel intensive, so trying to get your techs up there, and it's going to require a one-to-one usually, whether it's done in the hospital or at the rehab services. It's not going to be the easiest thing to accomplish. Particularly if your lab is backed up, like many of our labs are, getting these patients all wired up could be a bit of a problem. They may not sleep well with it. So, and then, do we need to get the AHI? So this is just going back to that issue I mentioned earlier about the hypoxic burden and atrial fibrillation in stroke patients. These are just oximetry tracings, 3 patients, similar AHIs. The top one there is someone who's having really arousal-based sleep apnea, so they're waking up before they desat, but their AHI is still quite high. The second one is an individual probably having more REM-related sleep apnea, where you're seeing some desats episodically during the night. And the other person obviously has very bad sleep apnea, a lot of hypoxia. This may be an individual who's just having long apneas and getting a hypoxic result of that, so their AHI may not be quite as high as you might imagine. Just relying on the AHI, which I know is obviously an area of controversy in sleep medicine right now, how good is it as a marker and a prognosticator? A lot of focus these days on hypoxic burden. It's just the issue of what do we mean when we say hypoxic burden? There's a lot of different definitions being thrown around for that. So that brings up the issue of doing home testing or limited channel testing. The advantage is here that they are, need somebody. You have the power to do that?
Yeah, since you're logged in, that's me.
All right, so 8 home or limited channel studies, obviously less costly, done in home or, more easily applied in the hospital setting. Obviously, they carry some disadvantages. You don't get all the data that you would like all the time. There's no technical support. You can't watch these real time for the most part. So if a flow sensor comes off, oximeter comes off, and the data is lost, the test may be useless. Some of these things aren't standardized. Some are. It's a big area of research going on, trying to figure out how to do this because not all these things have been validated. And you can't have false negative rates, although probably less of a concern in this setting if we're really concerned about more of the hypoxic burden or capturing patient moderate severe sleep apnea. I think that's more of an issue, particularly patients that have milder sleep apnea, and particularly women that are more arousal based, which often occurs in women. Surprisingly, so this was part of this large review on just sleep disorder breathing that was published. And I was stuck with doing part of the diagnostic thing and looking at some of the patient populations that we look at and utilization of different diagnostic testing strategies. When we looked at HSATs to see how many times these have been validated, so there's a number of feasibility studies, and yeah, you can do this, and we think it's accurate, but in terms of validating it compared to straight with PSG, there's only been a couple of studies. The time I did this, the only one I picked up was this one, which had 21 patients in it. It did suggest that it was accurate, but it's an N of 21, so it's a little bit hard to say for sure that it's if you were really doing an academic study, you'd probably want to make sure it's validated. There was one other device, and I think this was a flow-based device that was in this other study. It was the Emboletta device. The Brizo diagnostic, which is a pulse ox and actually an acoustic sensor. So it is put at the sort of the sternocleidomastoid junction there. Again, tiny study, just 23 patients, but it suggested it was fairly accurate at picking up an AHI more than 15. But those are the only 2 studies that I've seen where they did validation work of the HSATs in this setting. Not to say people aren't doing this clinically. Like I said, it's been shown to be feasible. Probably most of the time it's going to be good enough. But just in terms of thinking about true accuracy, they haven't been very well studied. This is from that study, looked at the Emboletta using the 4% desaturation rule, and you can just see the accuracy of the device. So that brings up in the last sort of objective testing tool is just doing simple oximetry. So obviously limited unattended, you only get 2 channels, it's a heart rate and a pulse ox. Big advantages, super cheap. It can be done just about anywhere. Obviously, you're getting limited data, there's no technical support. And interpretation, as we've studied here at the case, has been shown not to be very well standardized. So you show an oximetry, a number of us, you may get different impressions on what they represent. Again, you see false negatives. Again, those are mostly arousal based, probably less of an issue. Probably one of the biggest problems with just the oximetry is that obviously you can't establish a formal diagnosis of obstructive sleep apnea. There is some data that you can't really differentiate central versus obstructive sleep apneic events reliably. So that's one problem. But 2, no insurer accepts this as a formal diagnostic tool in order to get treatment, which is really what you're trying to get to. You could argue, and we'll come back to this, which what we did because of resources and simplicity, is we actually do use this, but it's more sort of utilized as a risk stratifying tool. So not necessarily yes, no, you have sleep apnea, you don't, but you probably have sleep apnea, it's really bad, we maybe want to do something sooner versus maybe you have sleep apnea, this can wait, we'll assess you later. And that same review, again, there were a number of very small studies that suggested that they could be accurate. And when you look at, particularly when you look at defining your sleep disorder breathing as having that 4% desaturation, right? So if you're not using 3% in arousal, you're just using 4%, you're doing oximetry in comparison, that's actually going to be fairly accurate in terms of the respiratory events. Now, again, there's the issue of central versus obstructive, but if you're only relying on 4% desats to define sleep apnea on a PSG, oximetry is going to be fairly accurate. So that gets us to the treatment portion of this. So, the big messages so far, OSA is very, very common in these patients. It's grossly underdiagnosed, certainly beforehand, and unless you probably do some sort of systematic approach to evaluating these patients, you're going to still miss it if you just rely on history physical to try and pick it up. There may be some screening questionnaires that can help you sort of dichotomize patients in terms of workflow, but objective testing is probably needed, at which unfortunately the data is a little bit limited, and I think you have to balance, think about your own institution and resources and how you want to proceed with things, but there are options available. So if you do find that someone has sleep apnea, whether it's by PSG, HSAT, or oximetry is suggestive, what do you do about this? And so PAP therapy, again, usually our first line therapy, obviously it's easy to utilize in terms of from a resource standpoint, it's widely available, cost isn't going to be that much, but there are issues with it in the post-stroke population. So these are studies looking specifically at patients who've had a stroke, found to have OSA, and then offered PAP. So up to 25 to 50% may refuse it. This is old data, might be better now. Probably that depends upon the resources you invest in education and discussion and whatnot. Compliance does tend to be worse as patients get older, if they're less sleepy. We kind of know that from the general population, but also if they have more severe functional cognitive deficits. So if they're going to have problems processing and understanding what this is doing for them or how it's helping them, if they may have problems with just needing a lot of help to put it on or take it off, those can be issues and are going to affect compliance. And initial data suggests that long-term compliance, looking at 5 years, was quite poor. This was one study, about 15%. But more recent data, so this is a study from 2019, suggests that it may actually not be quite as bad as we thought. So this is looking at 3, 6, 12 at the 5-year, 60-month compliance. You see there at the year, it was actually around 50% we're still using it, which is not that much different from the general population, and 40% at 5 years. So suggesting that probably with the right, in the right setting, the right patients, and the resources and support, you can change some of those outcomes. So does CPAP impact outcomes? So this is really the big question mark right now. We'll just run you briefly through. There's been a number of very sort of short-term studies looking at this. They're all randomized controlled trials. The biggest problem is they're all tiny. So they're no more than 40 to 45 patients in all of them. So this study was a post-stroke patient. They just randomized patients to AutoPAP for 30 days versus usual care. So here it's 15 versus 16. So they started the AutoPAP then 48 hours. I think this was the study where they did it without even testing them. They just said the prevalence rate's so high, we're just going to put people on PAP. And they actually found in their study at a month, almost 2/3 were compliant with the PAP, and they found that their NIH scores improved when they used PAP compared to those that were randomized to not using PAP. And the more they used it, the more hours they used, the better their NIH score tend to improve. This was a study where they had a PSG, and then they randomized those with an HI more than 15 to PAP versus unusual care versus PAP, or versus just usual care. It's on rehab service. And they found at 1 month that they showed improved functional and motor outcomes, but no difference in neurocognitive outcomes. So just remember that functional and motor in this study. So this is another study in which patients post-stroke, 20 in each group, AutoPAP, these a sham CPAP in this one, so which is probably a little bit better standard. Again, up to 1 month. And they found improvement in the cognitive outcomes, but not the motor outcomes. So all these studies are showing some improvement in various domains, but it seems like it depends on the study in terms of what domain gets better. And then this final one, so these are the kind of the 4 big randomized ones that were done early. Again, this one had HSAT testing, HSAT REI more than 15, and they looked at PAP, unusual care versus no PAP, so 20 and 16, 1 month follow-ups. And what you saw in the PAP group was that their improvement in attention, memory, and executive function with some of those that did not have OSA, and was much better than those that had OSA but weren't treated. So again, it's a bunch of small short-term studies, hinting at improvements in a variety of different outcomes, functional, some show functional, some show cognitive, depending on the study. So other studies, now these are not randomized controlled trials. This is looking at, does CPAP impact subsequent stroke in patients who already had a stroke and diagnosed with OSA. And so in observational studies, it appears that that's significant. So you can see the risk ratio down here certainly favoring using PAP. When you look at in CVA related mortality as well, it looks like that it may improve mortality. But big problem again, none of these are randomized controlled trials. And we know from all the discussion about observational studies and randomized controlled trials, just in general sleep apnea, that these can be problematic. We see sort of the same sort of thing. This was actually a randomized controlled trial, 126 patients with an HI more than 20, and they're randomized CPAP unusual care, just usual care, and they followed these patients for 5 years. And looking at cardiovascular survival and cardiovascular event being event-free, those that used PAP did do better. And the p-value is 0.02 for survival and 0.06, so not quite significant for just having secondary cardiovascular events. So certainly very suggestive, and this is not those short-term, recovery studies. This is a more longer-term study, but it's not huge, only 126 patients, so certainly suggestive, but not conclusive. So when we talk about other treatment options, getting an oral appliance, you guys all know, can't get, trying to get that in a rehab service would be virtually impossible. They got to see a dentist, got to have impressions made. Those are usually sent out, then adjusted over time, takes often weeks to months really to get them optimized. And some of these patients aren't able to hold it in their mouth. And so there's problems with doing that. Surgery, no surgeons, just had a stroke, no surgeon's going to operate on a patient. I don't care if they got huge tonsils or really deviated septum or something, they're going to say, wait till they.
Okay.
Medications, obviously, right now, until we find out what happens with Apnea Med, do not treat the OSA. Sometimes, but obviously use stimulants as adjuncts in these patients in general, which can improve daytime sleepiness if they are hypersomnolent. But this one study suggested that they may actually increase the risk of second CVAs, but it wasn't very well done or conclusive study, but there was an association. Other things we've talked about in terms of other treatment options and nasal valves, hypoglossal nerve stimulator, negative pressure devices, or the wings. CNAP is probably contraindicated in these patients. because they often have vascular disease in their carotids. So these are not going to be real options. Interestingly, there's a couple of small studies just looking at some of the things we don't traditionally think about in terms of frontline therapy, but oral pharyngeal exercises. Again, this probably gets the upper airway dysfunction that some of these patients have as a result of their stroke. So this may actually improve outcomes. There's one small study that was published 6 years ago. They did show some improvement in some of the functional outcomes and the sleep apnea with these patients. And then just doing something simple like keeping them off their back, elevating the head of the bed, can reduce their apnea-hypopnea index. Oxygen, obviously, this is maybe more treating us. It prevents the hypoxia. Theoretically, you could argue in this situation, if they're getting hypoxic 8 hours during the 24-hour time period, and that's driving problems with recovery from brain ischemia, maybe there's some benefit to it. It really has not been studied in this setting now. Obviously, it does not treat the OSA, so you might still get sympathetic surge activity related to the airway collapsing. So it'd be interesting, but to look at this, but it has not been studied yet. So just to summarize the points, again, very, very common, may not present typically. There's a fair amount of data suggesting it's associated with worse outcomes. It can be diagnosed, but again, it depends upon your resources, the availability, and feasibility at your institution. And then treatment may improve outcomes, although there's still a big question mark here. You need a bigger, better data. So we'll come to that, sort of what the study going on now is. So I just want to spend a few minutes to talk about what we've done at Metro, because given our situation. So it is kind of hard to capture a lot of these patients, as they move patients in and out of the hospital fairly quickly these days, and so trying to get any kind of study on them and intervening with therapy can be difficult because they're often discharged to another facility within 2 to 3 days. So what we decided to do was capture them when they hit rehabs, and they're there for 3 weeks generally. It's a one team taking care of them. It's very focused service. And initially, when we started this, we actually had to sleep right by the rehab facility, so it actually worked out pretty well, so we could cross fertilize in terms of our resources there. Now we don't have a lab there anymore, so it's become more difficult. So as a result of that, we end up just doing sort of this, like I mentioned earlier, sort of a risk stratifying oximetry to try and assess how hypoxic these patients are. Does it look like they have bad OSA? If they're on oxygen, do it on the lowest setting. And then kind of an assessment. And so we do leave this up to our rehab folks, in terms of, are these patients a candidate for PAP therapy? Are they cooperative and agreeable? Can they handle their secretions? Can they remove the mask if they're in trouble at night? Don't have an NG and things like that. So it's a little bit complicated, but the main thing is looking over here on the right. So if they had it, we kind of went based on the stroke literature, ODI 3% or more than 10. And initially we were doing this, putting these patients on auto PAP. So we didn't have to have technicians there once our lab moved, so that our Ts would be doing this, which is not always optimal. We get a download, repeat oximetry, reassess, make adjustments. And then prior to discharge, when we initially had the lab there, we try and get a limited channel study on them. If that was not feasible, what we more often do now is try to get them to the lab soon after their discharge. Because you can't, just based on this protocol with the oximetry, you can't get them auto PAP to go home. Now, if they're going to a nursing home, they're able to get it because the nursing home can supply it and they don't have to follow those guidelines. So we did this for a number of years. We decided, let's go back and look at it and see. So I had a student that was looking for a project, so this is a great project. So this is just a couple of things here showing you some very, so you always want to kind of show your best cases. So this top one, so the ODI 3% in this individual, this oximetry on top and the heart rate on the bottom. You can see all those just DSAT. So they've got terrible sleep apnea. Their ODI is 46, and they're spending a lot of time with SATs, less than 90%. So put on auto PAP, repeat oximetry. You see lowest SAT there is like 88%. Almost all the time they're over 90%. Still some sawtoothing, it's not optimal. But their ODI came down to 10. So you got to think this has got to be helping this person, but we don't know that 100% for sure. It's another one. So probably classic oximetry suggesting very likely REM-related sleep disorder breathing, just based on where it's spaced out. You see the profound desaturations down 70%. ODI is 33, put them on an auto PAP, and you can see oximetry dramatically better. Very little hypoxia, ODI is down to 5. So, we thought, yeah, we gotta be doing great things for these folks. Let's actually go and analyze the data. So we know that rehab is tracking these FIM levels on these folks. So we went back to do it, just to retrospectively look at this, and we broke the patients out of low risk to high risk. We had about, it was like 55, 60% or high risk OSA based off their oximetries. And then we recommended PAP therapy. So one of the limitations here is our rehab site is now, it's off campus, it's a different facility. We don't have the resource to run over there and see all these patients. We don't have the resources to have a sleep tech there helping with these patients. So we're really left to the, sort of counseling from afar and hoping for the best. And we went back into these charts of these folks to see what happened. People were recommended auto PAP, and it was a little bit rudimentary in terms of determining adherent versus not adherent, but actually looking at day-to-day documentation of PAP use and whatnot. So we had only 12 patients we consider to be actually adherent with therapy by standard definitions. And then we had a lot that were kind of just failing. So only 12, so less than 10%. When we looked at the oximetries, just comparing baseline to on PAP, it did look like a pretty significant improvement. ODI 3% going from 29 down to 4. So it looks big, but then there's a second step of, are they actually compliant with their therapy, which the majority were not.
Did that surprise you, just given some of the data you reviewed, that it maybe not so bad?
I was hoping it would be better. But again, it's something, this is kind of a real world experience. So in some of these settings, they're in research settings and you have a lot of support. We're a little bit handicapped here because, again, like I said, we're relying on people 10-minute drive away. We don't have sleep techs there. We're not on site. So, you need a real champion there. You got to use this, you want to, RTs that are really invested and all that. So we looked at their FIM scores, and it turns out, at least in this study, that they really weren't much different whether or not you had sleep apnea and whether or not you got put on PAP or urine therapy or not. So both cognitive and motor. We did try to do an adjustment of looking at those that were actually even more compliant, and we did this big matching of all these folks and found that it didn't really make a difference in their overall FIM scores. Actually, there's a little bit worsening in the total FIM, but wasn't clinically relevant according to our rehab colleagues. So we sort of took a step back. We are still doing this screening, but less aggressive with the PAP therapy on these folks, because at least in our hands, the way we're doing things from a workflow standpoint, it is still somewhat resource intensive to do that, and we're not clearly impacting their outcomes. So we decided we're a little less aggressive. We'll treat patients that are really bad, but oftentimes we're saying, okay, we'll get an outpatient sleep study and take it from there. So because of the sort of the question marks about how treatment impacts outcomes, the Sleep Smart study was developed. I think UH is a site for this, right? We were
Sites, yeah, through neurology.
Yeah, we were a site as well, but we had to drop out because of that problem, because you have to capture them in the hospital, and we were having trouble getting these patients before they could move off site. So it's a very simple study. It's designed to determine if you have sleep disordered breathing post-stroke. If you come in a stroke, sleep disordered breathing, put them on auto PAP, and then determining, does it actually make a difference in 3 and 6 months outcomes. I'll show you that in a second. So large study, 5 years, 110 stroke centers across the country. The study was unfortunately really harmed because it started right before the pandemic. So I don't know if the last I saw was it was supposed to be 3,000 subjects, and it's just over 1,000, and recruitment was kind of coming in at a trickle. So the pandemic really hurt it. Took a lot of that wind out of the sails. But fairly simply, you just had to be more than 18 and have a TIA or stroke. There's some exclusion criteria, most of which, you can't be pregnant, can't be on a ventilator, can't use PAP for whatever reason. And this is the way they're doing this, which I think is pretty smart. So again, they're hung up on that cutoff of 10 for whatever reason. So patients that are admitted with a stroke agree to be in the study, they get a NOx study done. which will help, can determine, so it's an unattended study, but can determine, obstructive versus central. So they have to have obstructive events more than 10 per hour. And then they don't just randomize them there, they actually do a run-in night, where they put them on autopap for night. And if they use the autopap more than 4 hours, it looks like someone's gonna be adherent, then they get enrolled in this full study and randomized. If they don't use it, if it's not something obviously fixed, they'll give you a second shot, like if, something happened weird, you can go back and retry one more night. To see if you can get them enrolled, but if they can't tolerate the PAP, then they don't get enrolled in the study. So what they're looking at then, so they get randomized again to autopap usual care versus usual care, and they're looking at 3 months, the functional outcomes, neurologic recovery and quality of life, and then 6 months, you're gonna look at more hard cardiovascular outcomes. So I'm not sure what's gonna happen with this study because it's unfortunately because of enrollment issues, if it will reach the full power it needs or not, but hopefully we'll hear something in the next couple of years about it. They're really working hard on it, so, but it's a large study like this is needed. If it does show benefits, then it probably is going to change a lot of our practices in terms of, being more aggressive with trying to diagnose and manage sleep apnea post-stroke. All right, so with that, I think I will stop.